not heard him in our gynae conferences as much, but I thought bringing Rohit here is to tell you how to remain healthy the nutrition way. So, though he is a director for the Vitabiotics and a degree in pharmacy, plus in a degree in natural medicine, so which is important that we would like to see what Rohit has to tell us, that a healthy adolescent is a healthy mother, is a healthy pregnant woman, as well as a healthy menopausal woman. So what we have here is that he's got multiple activities. Nonetheless, even the new movie that is coming up, Panipat, he is the producer for that movie. So all of you, please be clear that that movie is, starring Sanju Dutt in that movie. But apart from that, I think he is also a director for the trust, which is called the Maratha Foundation, where farmers lost their jobs and their crops. This particular Maratha Foundation helps such people, a noble cause. Thank you very much, Rohit. We'll pass the mic on to you. And the extremely good looks is because of the nutrition. Okay? And the smile on his face is because he's still not married. Okay. Thank you very much.
Okay. Thank you for the introduction, and also very kind of you to mention Panipat. The film is releasing on 6th of December. And I really hope that all you doctors support that cause as well. Profits coming from the film is also going to the welfare of farmers in India, so nobody is going to take any money out of the movie. Let's talk about fertility and nutrition. I'm here to share my experiences in fertility and the role of nutrition in fertility and what work we do in the UK in our clinics. I've worked with universities around the world, and particularly in the Western world, and would like to share some of the experiences. So these are the contents of the topic today. But we'll talk about, when we talk about conception, it's important to understand that it's a story of transport. The sperm being placed at the top of the vagina, then it travels, meets the egg, and them to fertilize. But there's no test really in fertility treatment that really tests this transport. You can, from a good history, know a lot about the sperm. You can, from a good history, know a lot about the egg, and you can, from a good history, know a lot about the chances of them two getting together. So at fertility clinics in the UK, what we do is a lot of counseling before we start with the treatment. And how we start is simple questionnaires to the males, to the females, and questions to the couples. So for example, the questions we'll ask a woman would be, if the periods have been irregular, if she bleeds in between periods, if there is a regular, sexual life, active sexual life, if she is above 35 years of age, if she is obese, diabetic, etc. To the men, we generally test if they've gone through surgeries of their testicles, any hernia treatments, ejaculating problems, etc. And as a couple, we've tried to find out how much time they spend together, is there any genetic disorder in the family, etc. But the one common question we ask all the couples is about their lifestyle and nutrition, how good the lifestyle is and how good the nutrition is. And that's why it's very, very important that nutrition lifestyle becomes the prerequisite of any fertility treatment, particularly in the UK under the NHS. So there could be various lifestyle factors that can affect fertility, and it's very important for doctors to speak to their patients at this stage about nutrition deficiencies and supplementation. In the UK, 1 in 7 couples cannot conceive naturally. About 3.5 million people, in a very small country of 65 million people, 3.5 million people, about 5% of the population is going through infertility treatment. This infertility is the most common reason why women in the age group between 20 and 45 visit their GPs in the UK. And that's why I say lifestyle factors must be considered even before starting treatment: age, stress, alcoholism, smoking, etc. And we are going to look at few of the lifestyle factors that we have researched into. Alcohol. Now, we're not talking about alcoholism here. We're talking about moderate level of alcohol that most of us get indulged in. About 40% of male infertility or subfertility is related to alcohol consumption. It reduces the level of testosterone and also speeds up the conversion of testosterone into estrogen. it reduces sperm count and sperm motility, and the breakdown product of alcohol in the body is an aldehyde that is toxic to the health of the sperm. And in females, if you think about it, females who drink have a higher excretion rate of folic acid in their urine. And when you talk about nutrients and fertility and pregnancy, folic acid is probably one of the most important nutrient. And excretion of folic acid expedites when you're drinking. And this drinking, as I said, is not about alcoholism. Just 2 units of alcohol a day for a woman, for a week for a woman, just 2 units, it's not a lot, increases prolactin levels and can cause hormonal imbalance. It can cause cessation of periods, amenorrhea, it can cause ovulatory disorders, and so on. And same with the smoke. As we all know, testosterone levels go down with smoking. It affects sperm count and sperm motility. But the smoke chemicals in smoke reduce vitamin E and zinc in the body of the male. And these 2 nutrients are, specifically very strong antioxidants, and they preserve the health of the sperm. Scientific studies have now shown that men who smoke more than 10 cigarettes a day reduce their sperm count by 15%. Men who smoke more than 20 cigarettes a day, they are born with babies with developmental cardiac problems which manifest later in their lives when they grow into adulthood. Women whose partners smoke more than 20 cigarettes a day have a higher chances of miscarriage. And then again, smoking is very, very bad for women as well. It thins the endometrium, it thickens the zona pellucida, the bag that carries the eggs. There is also scientific studies that have shown that smoking adds 10 years to the fertility age of the woman. So a 25-year-old smoker woman has a fertility age of 35. And that has also been seen in various clinical trials we have done. Caffeine intake, I'm not a particular promoter of telling people not to drink coffee. I think the infertility caused by caffeine is not mainly because of caffeine, but because of other lifestyle problems, because of which the patient may be consuming a lot of caffeine. So although it's a small factor, not a very big one, being overweight or having a high BMI has, of course, a lot of negative effects on hormones and fertility in general. So what we have designed is a fertility diet. We call it a fertility diet, and it's very simple. Add a lot of fiber to the diet, replace your simple sugars with complex carbohydrates, add protein to the diet, and make the diet fertile. And when we put women on fertility diets, the study was done on 17,500 women. 66% reduction we saw in ovulatory disorders related infertility, and 25% reduction in infertility due to other reasons, just by having a healthy diet, which we call a fertility diet, rich in fiber, etc. So women ask me, when does the menopause start? The answer is that menopause starts when the woman runs out of eggs. But when does the woman start losing eggs? The answer is at the time of birth. If you see there, the woman is born, the baby is born with 1 million eggs, and then she continuously loses her eggs during her lifetime. But 20 weeks in uterus, she had 5 million eggs. So she has been losing eggs even before she was born. And if you think about it, we are all born from the egg that our mothers gave. So we are born from the egg that is the same age as our mothers. And the egg quality just declines with age, and the egg release number also declines with age. This is not the case with sperm. Sperms are produced every 12 weeks, and hence we always say at the clinic that it is much more easier and challenging, of course, but very easy and gives better result to treat male infertility. A good lifestyle, good nutrition of just 12 weeks can improve the sperm count and the sperm motility in men. And hence we also say, if we look after the couple of today, we are actually influencing next generation, something that is coined the term as fetal programming. We look after the next generation by looking after today's generation. And this is a little diagrammatic representation of how, with age, the odds of getting pregnant naturally reduces. And that could be because of reduction in ovarian reserve, early menopause caused by bad lifestyle, thinning of the endometrium, different diseases and problems in the reproductive system like endometriosis, PCOS, etc., which are now all related to a bad lifestyle. So as we all know that the egg quality declines with age. After the age of 35, really the quality is very bad. At the age of 40, only 10% of the woman's eggs remain normal. Now this decline in the release and the quality makes it very difficult to have a normal embryo even after IVF. This is the first mid-luteal phase. The corpus luteum is formed in that phase, and at that phase, right level of antioxidant supply like vitamins, minerals, coenzyme Q10, different amino acids become very important to hold pregnancy in the early stage. Here are some antioxidants that we frequently use in our treatment: coenzyme Q10, N-acetylcysteine, alpha-lipoic acid, L-glutathione are a few to be mentioned here. Egg gradually develops into a process of folliculogenesis where the follicles replicate. Now this process needs a lot of glutathione. Body cannot produce enough glutathione in the absence of the antioxidants and the amino acids, and hence why supplementation at this stage is very important. Supplementation with antioxidants like coenzyme Q10 can do a dual effect. One is it gives you the extra energy that is required at this stage, and it also protects the mitochondrial DNA against oxidative reactive species, the ROS. So the big question here is, through nutrition and through a healthy lifestyle, can you augment the quality of the oocyte and the embryo competency? Now, there is a beautiful editorial on Reproductive Medicine Online, June 2016, where this topic is nicely discussed, which talks about how oocyte competency can influence embryonic competency. Oocyte competency is basically the intrinsic competency of the oocyte to carry on meiotic maturation, fertilization, embryonic development, and a healthy pregnancy. Now the various factors that affect this, and it's commonly known that with age decreases, the oocyte competency decreases because gametes are not, they cannot carry on the meiotic division properly, which means there could be aneuploidy, there could be problems with the chromosomes. At this stage of this division and maturation and fertilization, there is a heavy demand of energy, and also the source of energy changes from glycolysis to oxidative phosphorylation. Now in order to prepare your oocyte for this shift in energy source, there's a heavy demand of energy and a heavy demand for mitochondria to produce more DNA. Now this excessive DNA puts a demand on ATP generation, which is the energy for life. And that's where ingredients like coenzyme Q10 play an important part. There are several clinical trials that show that when the conversion of oocyte to blastocyst happen, there's a decrease in the level of mitochondria. And the initial embryo that is formed is completely dependent on the oocyte mitochondrial DNA for it to function. And for that stage, something like coenzyme Q10 could be of big help. This is how it happens. Coenzyme Q10 is a vitamin-like substance, but it's fat soluble. So it's also very important that when you prescribe or you recommend coenzyme Q10, look for a fat soluble or liposome-bound coenzyme Q10 that gets absorbed in the presence of food when there is fat in the stomach. And coenzyme Q10 is an intrinsic molecule for the electron chain transport system, which gives out an ATP molecule producing excess energy. This is a paper by Professor Robert Casper. He's a big name in the antioxidant research, particularly in coenzyme Q10. We have done a lot of work with him, and he has summarized how a compromised oocyte can cause infertility because of lack of mitochondrial DNA and because of lack of energy. There are various human and animal models that have shown this, and when the studies were done, IVFs, we have seen that high-grade embryos contain high levels of coenzyme Q10. Coenzyme Q10 given in embryo medium can also show improved blastocyst rate, improved hatching, extra ATP content, and good cell mass for the blastocyst. So the answer to that question that I asked in the beginning is yes, nutrition and lifestyle products can augment the oocyte competency, thereby having an influence on embryo development. Nutrients are important, and here are some of the recent studies that I have mentioned, but there are thousands and thousands of studies and that you can find and relate certain specific supplements to fertility and pregnancy. We are going to look at some ingredients that we feel have worked at our clinics. B12 and folic acid. Now, really gone are the days when we only knew that folic acid is the most important nutrient for fertility and pregnancy. After John Scott, Professor John Scott from Dublin, he published his studies, his work of 20 years on B12, vitamin B12 in 2012. In the last 7 years, several departments of health of several countries, the UK, the US, have now put official representation, official recommendation for B12 to be given alongside folic acid, because folic acid alone would not work unless B12 is supplemented alongside it. We are very proud that we support a charity called Shine in the UK. It was formed in Ireland, but now majorly based in the UK, which works in the promotion of this Go Folic campaign, where we counsel mothers to be on folic acid and B12 even before they decide to conceive. Vitamin C, again, it's very easy to be deficient in vitamin C because we depend entirely on our diet for this vitamin. And our diets are not from scratch. We don't have enough vitamin C in food. It has a deficiency can have a negative effect on the second half of the women's cycle. So it not only influences the release of eggs, but it also influences the quality of eggs, and hence appropriate supply is very important. Iron. Lack of iron is lack of release of eggs. And anemic women may find it very difficult to conceive anyway because of chronic illnesses. But if she conceives, there's a high chances of SGA babies, small for gestational age babies, or babies born with developmental cardiac problems that manifest later in life. Hence, I'll repeat again what I said earlier, by looking after the women of today, we are doing fetal programming. We are programming the life of the fetus, the next generation. Zinc and selenium, I've already heard in the last presentation, the discussion, doctors mentioned how selenium is important and how zinc is important. Now, in fertility, zinc particularly has a dual role. It has a direct and an indirect effect. The direct effect is that higher the level of zinc, higher is the level of FSH, promoting ovulation. And the indirect effect is if the level of zinc is lower, there is generally higher copper in the body. Higher copper in the body will reduce progesterone and have a negative effect on ovulation. Selenium and zinc deficiencies are actually interrelated. If you are deficient in zinc, there would be an underlying deficiency in selenium. So when zinc deficiency is identified, generally selenium and zinc supplementation should be given together. And anyway, selenium is good for the male and female reproductive system, both. L-arginine is an antioxidant and a very strong natural amino acid. It helps with implantation. N-acetylcysteine is widely used now in treatment of polycystic ovaries. Inositol is used in the treatment management of PCOS. Again, it helps in cell membrane formation and also improves sensitivity to insulin. And that's why it's important that the whole palette of vitamins and minerals, amino acids and antioxidants are all given together. Like we have it in food, we don't have isolated nutrients when we eat food. Or because we don't get these micronutrients from the macronutrients that we eat, it's very important that when you give a supplement, you give a whole palette of vitamins and nutrients. You will ask the question, but where is the science? Where is the science of all that I spoke? I spoke about a lot of individual ingredients. The science is here. So this is a colleague of mine, Dr. Reena Agarwal in the UK. We conducted a clinical trial at the Royal Free with Warwickshire University. We saw the supplementation during IVF treatments improved results by double. So improved the chances of women getting pregnant in subfertile women twice as much. And this is a worldwide coverage. It got a 30-pence pill that can double the chances of you having a baby. So very ideal way of starting your counseling and then getting a patient on supplements before you start treatment with pharmaceuticals. We're very, very proud to tell you that the first time Queen's Award was given to fertility research for nutrition. And I was fortunate enough to meet Her Highness the Queen and receive the award for our research in fertility in 2013. Thank you very much. Very interesting slide. That is, that white portion you see there is the time when you're trying to conceive. The blank portion you see in the middle is the time when the woman actually conceives. And the green portion is when she knows she's pregnant and she starts a supplement. Now, in the first 4 weeks, she may not be aware that she is pregnant, and that's when the neural tube of the baby is formed. So if she is not aware that she is pregnant, she would be missing out on her nutrients, the folic acid, the B12, the vitamin D, etc. And that's why it's very important. Preconception supplementation becomes really, really important. We advise women to get on their supplementation when they start thinking of getting pregnant. Male fertility, as I said, it's easy to treat, and it's very, very important, just as important as female infertility. Research has shown nutrition deficiencies can cause reduction in the sperm count, sperm motility, and also interfere with the sperm morphology. Only about 25% of men have the right level of sperm health. That is, only 1 in 4 men have a right level of sperm health. So there are a lot of natural ingredients that you clinicians can look at. I've only mentioned a few here. The one that is missing here is maca extract. I've been really talking about maca extract. We've been working on maca extract for a long time. It's particularly popular in the US and the UK for fertility treatment. It comes from the root of maca plant, which is grown in the Peruvian region of Central America. We have lycopene, a very strong antioxidant coming from red tomatoes, which is now widely used in the treatment of prostate problems for men. Ginseng has been traditionally used for sexual dysfunction for many, many hundreds of years. And then pine bark extract is a very strong antioxidant that protects the cell wall and the structure of the sperm. We generally ask our patients to avoid soya if they're trying to, if they're going through fertility treatment, especially men, because soya has got isoflavones and they have estrogenic characters, so, and they bind to estrogen receptors in the body, the isoflavones. So we generally not recommend soya to be taken by male infertility patients. Here's a clinical trial that we conducted on male infertility. We saw just in 12 weeks of treatment with the right level of supplementation, a 67% improvement in the sperm count and the sperm motility. It also affected sperm morphology. There wasn't a very significant increase in the number of births following the result, but definitely improvement in the sperm structure, count, and motility. Again, as I said, for the female fertility, it's very important that you have an entire palette of vitamins and minerals, selenium for spermatogenesis, zinc, vitamin C as antioxidants. L-carnitine is a very important amino acid that helps in linear movement of the sperm. Clinical trials have shown a very good improvement in sperm motility with just about 3 months of treatment with 50 milligrams of L-carnitine. So we have looked after the man, we have looked after the woman. Now let's have a look at importance of vitamins in pregnancy. A colleague of mine at Oxford University, Professor Ron Gray, made a very important statement in the press in 2012. He said that malnutrition or inadequate nutrition in pregnancy can cause congenital as well as developmental cardiac problems in the babies born. And that's why, I'll repeat again what I said something twice already, that by looking after the woman of today, you're actually fetal programming. You're programming the next generation. So again, some important ingredients that I specifically put thrust on when I talk or when we are at clinics is vitamin D. We talked about immune response in the previous presentation. And the one, if I was to pick one ingredient, one natural nutrient that helps with immune response, especially in pregnancy, and is related to preterm births, preeclampsia, and miscarriages, the common factor, the common deficient factors in all three problems is vitamin D. Since we don't get enough vitamin D from sunlight, the UK Department of Health recommends 10 micrograms of vitamin D during pregnancy and during breastfeeding. A national survey has shown 15% of all women in childbearing age are deficient in vitamin D. But in my view, this is a very, very, conservative figure. If we were to test vitamin D levels of this crowd in this room, I'm sure most of us will be deficient in vitamin D. And it's such a, why vitamin D, I talk about vitamin D all the time, is because the body is made of trillions and trillions of cells. And if there is one receptor that is common in every cell of the body, these trillions and trillions of cells in the body, if there is one common receptor, it is the cholecalciferol receptor, the vitamin D receptor. So if you really ask me, as a nutrition expert, what is vitamin D good for, I may probably not be able to answer it in one day. I'll have to talk about vitamin D and different systems and organs of the body, but here we're talking about fertility and pregnancy, and this is very, very important. We've just started a clinical trial which actually started last year, about to be concluded by the end of next year, at the University of Birmingham. We'll be looking at the effect of vitamin D in improving immune response in pregnant women, and also how it can reduce the incidences of preterm birth, preeclampsia, and miscarriages. Iodine. I'm not very sure about India, but in the UK we have a big problem with iodine deficiencies. And as you are clinicians, you would agree with me that if your patient is not having normal milk, if the patient is on soya milk, almond milk, for whatever reason, lactose intolerance, milk protein intolerance, etc., they're more than likely to be deficient in iodine, and supplementation could be very important. There's this study that was published in 2013 that shows that apart from having that profound effect on the thyroid hormones and the link with miscarriages, babies that were born to women who were deficient in iodine had lower IQs at the age of 12 than the counterparts and women who had good iodine levels in pregnancy. This was published in 2013, very recent study.
Sorry to disturb, sir. Another 5 minutes more.
Sure. News, iodine in news, how important it is. And again, iron, like we talk about fertility, iron is very important in pregnancy as well. About 1/3 of women around the world are deficient in iron, all women in childbearing age. We did an extensive study at Queen Mary's in London across 29 countries in the world, and we found that anemic women were more likely, twice as more likely to die during birth or straight after as compared to their healthy counterparts. So that shows the importance of iron. Now, I get asked a question frequently: why take a multivitamin when government recommendations, when the Department of Recommendations are only on B12, folic acid, and vitamin D? Why take a multivitamin? My answer is just about doing the best for your baby. Our diets are not from scratch. We are constantly following fat diets for whatever, looking well and looking nice, etc. Keto diets and low carb diets, low fat diets, etc. What we essentially do following these diets is cut on the macronutrients. When we do cut down on macronutrients, we don't get enough micronutrients as well. Even if we were on healthy diets and having the right level of macronutrients, we will not have the micronutrients that we need because of devaluation of food. There is a study that was published after 22 years of research in the UK that showed devaluation of 20 vegetables. Calcium level in vegetables have gone down by 27%. Iron levels have gone down by 37%. Vitamin A levels have gone down by 21%. And vitamin C levels have gone down by 30%. So today, if you were to get vitamin A from oranges, you will have to have 8 oranges. As compared to 40 years ago, our grandfathers had that level of 800 micrograms of vitamin A from one orange. Today, if you were to get vitamin C from oranges that our grandparents had 40 years ago, you will have to eat 50 oranges to get 800 milligrams of vitamin C. That is RDA. 80 milligrams, sorry, vitamin C is RDA. You have to eat 50 oranges. So devaluation as food is another reason why a multivitamin is very important. And that's why we have the range of Pregnacare supplements in the UK, now available in India as well. A little bit of history about supplementation. 1980 was the first time micronutrients were shown to have positive effect on pregnancy, particularly in the prevention of neural tube defects. 1983, further evidence came. 1988, we launched the first multivitamin supplement to support this. 1991, there were official recommendations and data to support folic acid and its protective effect in neural tube defects. 1993, vitamin B12 was identified as the independent risk factor for neural tube defects. 2012, the government made official recommendation for B12 alongside folic acid. Clinical trials that we did on supplementation showed that women with supplements not only showed better nutritional status, but it also reduced SGAs by 50%. After pregnancy, we recommend certain ingredients like iron, omega-3, calcium to be continued. Iron because of loss of blood, change in lifestyle. Omega-3 fatty acids because if the baby is breastfeeding, the only source of DHA that the baby is going to get is from breast milk. And calcium, of course, because there is a 15% loss of calcium in the woman's body at the time of breastfeeding. So these ingredients become very, very important. And post-pregnancy formulations for breastfeeding also are very, very important. So few points to take home. you need to take a multivitamin, not individual supplements. You need to take supplements that are supported by clinical trials. We support Shine charity that promotes the Go Follow campaign. All you doctors are more than welcome to join the group in the UK. You can join it online. It's called Shine Charity. And remember to ask a question whenever you encounter a nutrition product: where is the science? There is a lot of products in the market. There's a lot of products that will be introduced to you. Only trust products with clinical trials. Thank you very much for all your support so far, and thank you for listening. Thank you.
Thank you, sir. It was an illuminating talk. There is a small announcement. We have a small delay in the schedule, so I'm sure with all the interesting talks, all of us wouldn't mind delaying our lunch by another 20 minutes.
So any questions before I? Yes.
Thank you for a very vitalizing talk. Learned a lot from your talk. I just want a question regarding using L-methylfolate instead of folic acid, because there are recent papers that are coming up that excess of folic acid can lead to colorectal cancer later on and other forms of cancer. So what are your thoughts of using that instead of folic acid?
Okay. Methylfolate and folic acid are essentially chemically very similar. Methylfolate is a derivative of folic acid. In terms of safety, they're actually equally safe if they're taken in the right level. So the recommended level is 400 micrograms. If you take a 400 micrograms and don't exceed the dose, they're both very safe. N-methylfolate, however, is more bioavailable than standard folic acid. But in terms of safety, if the dose is maintained to 400 to 800 micrograms, the UK Department of Health recommends 400 micrograms. The US FDA recommends 800 micrograms. European EU, EMEA recommends 200 micrograms. As long as the dose doesn't exceed 1 mg a day, they are absolutely safe, all forms. But N-methylfolate is more bioavailable.
I'm talking about people who have MTHFR mutations, where this accumulation of folic acid or folate would be detrimental to the woman and the baby.
It won't be detrimental at a dose of 400 micrograms, but if you give L-methylfolate, the only advantage you have is you would probably get a similar effect with a lower dose.
Thank you. Thank you for your clarification.
Questions? Any more questions?
We'll go to the next talk, but we are getting Dr. Sarosh Rana because it's almost 2 a.m. in the morning in the US, and she will be on the webinar. Are we ready, Prakash? Okay. Can we have the JP brothers to come here, please? We could give you a minute or two. I just want to tell you that we have the journal. Can you have the journal slide on, please? No, the journal slides, please. No. Thanks. It was a good talk. Okay. So, the journal, International Journal of Infertility and Fetal Medicine, has been in vogue for many, many years. And I would like to say that we have a lot of contributions from abroad as well as from India. We would also like to say, Prakash, can we have that slide on, please? Okay. So we would like to urge all our gynae colleagues, if they have interesting case reports in fetal medicine or in infertility, to be able to come forward and participate in bringing in your papers into this journal. We are very keen in promoting clinical trials as well as research as well. So if you've done something that has given, some good outcomes, we would like to share it in this particular journal. So all of you, please look at it. It's an open access journal, 3 issues per year. It's Scopus indexed. And so therefore, for students as well as even for professors in medical colleges as well, putting it into this journal, you would also get your promotions as well. So please look at this. Please participate in this, because this would help you all the way around. And those of you who want to be peer reviewers for us, please get in touch with Dr. Divyashree and Dr. Deepika. They will be able to get you onto our peer review panel. And I'm sure that any of you who who would like to contribute, it will be my pleasure to have you on into this journal. It will be reviewed by 6 peer reviewers, and then it gets into this journal. Thank you very much. Is it finished? Is she on? So should we take our talk then? Huh? You know, at 2 o'clock. Shall we start? Okay. Thank you very much. 5 minutes. At least I can do at least 5 minutes of talk so that we don't waste time and I don't delay you on your lunch.